Welcome to VC Ag Today. I'm Robbie Longest, the Associate Extension Agent in Essex County for Agricultural and Natural Resources. Thank you all for joining us this morning. It's January 21st, 2021, and our topic of discussion this morning is the COVID-19 vaccine and what agricultural workers need to know. I appreciate us this morning. Am I coming through okay, Laura? I see a message from you to speak up.
I'm having a hard time hearing you, or you're a little more muted than normal.
Okay, just 1 second. Let me see if I can make some changes. How about now? Is that any better, Laura?
That is better, thank you.
Okay. All right. Sorry about that, everyone. Good morning again. As I mentioned, our topic of discussion today is COVID-19 vaccine and what agricultural workers need to know. We're pleased to be joined by Dr. Richard Williams, the district director here at the Three Rivers Health District. He also is part of the Virginia Department of Health. So we're pleased to be joined by Dr. Williams this morning, and he's going to be sharing some updates on this topic. I know we have a wide participation this morning from agricultural extension agents from across the state of Virginia. So thank you all for joining us. And we're all trying to figure out what may be our role as we move forward and what we could advise our agricultural producers to participate in and get the COVID-19 vaccine if they wish to do so. So just a few ground rules before we get started this morning. As always, if you have questions or comments, if you could please type those into the chat window. We will address those at the end of the presentation with a question and answer session. Also, if you would please keep your microphones muted throughout the presentation, we would really appreciate that to avoid any background noise or disruptions during Dr. Williams' presentation this morning. So without further ado, Dr. Williams, we appreciate you joining us this morning, and the floor is yours.
Thank you very much, Robbie, and I'm pleased to be with you. Just before we get going on this, just a few words about my background. So I'm an older guy. I was 27 years in the Air Force. First specialty was general surgery. Second specialty was aerospace medicine. I went through 2 armed conflicts in the Air Force. When I retired from the Air Force, I went to the National Aeronautics and Space Administration in Washington, D.C., where I was a chief health and medical officer of NASA. That's a pretty high level job in NASA. So I'm extremely familiar with goings on in Washington, presidential transition processes. I went through 5 of them there. I worked very closely with the National Institutes of Health and National Academy of Medicine and many of the best academic medicine institutions all across the country during my work at NASA. During all that time, I already mentioned I went through 2 armed conflicts. I've been through every pandemic or threatened pandemic that we've had: Ebola, H1N1, Zika, SARS-1, MERS. Been through all of those, went through the anthrax attacks in Washington, D.C., where we actually had anthrax in our building at headquarters NASA. That was interesting experience with anthrax in the building and 1,300 real rocket scientists that were there at the time. 5 hurricanes, major hurricanes that hit NASA centers, Hurricane Katrina, for instance, that I was directly involved in. In other words, I've had a lot of contingency experience in my life. I did retire from NASA 3 years ago, got bored quickly, came back to work for the Virginia Department of Health. I've known folks in VDH for many years, and they needed a health director in this Three Rivers district, so I came back here, and that's what I've been doing. And so for the past year, we've been in the most difficult contingency I've ever faced, including, bar none, which is the COVID-19 pandemic. And it's, like I said, it's not getting any easier. As a matter of fact, it's getting more difficult. So that's my background and context for the talk today. So let's just talk about the pandemic status for a minute. Most of what we're going to talk about today is the vaccine and the vaccination process, but we'll start with the pandemic status. You've seen cases wax and wane over the past almost year now. As a matter of fact, over the past year. Currently, we are we have been in a large pandemic surge across the country for many weeks. Most states, if you look at the data, are actually trying to get better at the current time. Post holiday surge appears to be waning down, and most states are getting better. Virginia still is pretty high. Our test positivity right now is at 13.6. That's an indicator of how much disease is out there, as well as how much testing you're doing. That's improved a couple of percentage points from a week ago. We have a little over 3,000 people hospitalized every day, 81% ICU capacity filled, and 36% of our ventilator capacity filled. That's really good news. You know, I don't think we're likely to see a pandemic surge much beyond what we already have seen, especially with the number of infections that are happening, engendering some immunity in the population, and then the vaccine program coming on board. So I think we might have seen the worst, at least with this expression of the virus, and it did not overwhelm our healthcare system. So I think that is really, really good news. When healthcare systems are overwhelmed, which we've seen in New York, which we've seen out on the West Coast, and so on and so forth, that's when death rates from this virus go way up, and death rates from other things go way up. If you get in a car crash or you have a heart attack, because of the high number of COVID patients in the healthcare system, you can't get taken care of. So that multiplies the hospital system. Overwhelming the hospital system is actually a force multiplier for the lethality of this COVID-19 virus. We're averaging a little over 6,000 new cases every day. That's a rolling 7-day average across the state. And here in Three Rivers, we've been averaging about 90 to 100 new cases per day over the past several weeks. So it's still quite brisk in Three Rivers, South District, and across the state. We could talk to a great extent about the pathogen itself, the virus. It's an incredibly capable pathogen. Of course, we still are learning about it. We're learning about the long-term health effects of it. We're learning about the acute phase of the disease and how it works to activate your immune system and use that to against you in a minority of cases, thank goodness, but it happens. We're learning about how it's capable of genetic drift. This is typical of coronaviruses. You expect it, but every one of them is a little bit different. We're learning how capable this thing is at the population level of drifting to new variants. Many of you may have heard of new variants emerging in the United Kingdom and South Africa and Brazil over the past several weeks. And past couple of days, we've learned about yet another new variant emerging here domestically in the United States and California. By genetic sequencing, these are all a little bit different from each other. They do all appear to be more infectious than previous versions of the virus, but not more lethal. And that would be commensurate with the evolutionary pressure that this virus has. It wants to, if you will, or it seeks to become more infectious, to propagate itself more readily, but it doesn't, you know, if it increases lethality, then potential hosts die, and that's not good for the virus as a whole. So it is evolving commensurate with evolutionary pressure. I won't say much more about the virus itself. If anybody has any specific questions about the pathogen, I'd be happy to address them. The only other thing I will say is we are also still learning about the human immune response to the pathogen. From natural infection, there's high confidence that there's at least 3 months of effective immunity following acute infection in the vast majority of people. Evidence is emerging that there may be as much as 8 months of good immunity in most people. The more time that passes and the more experience that passes with people that have had this disease, and we can track those folks over time, the clearer that evidence base will be. But right now, the confidence or the recommendation from the CDC is to anyone that's been infected with COVID actively within the past 90 days, defer the vaccine until after 90 days has passed and then take it. So that's the current recommendation. but a lot still needs to be learned about the immune response, not only to natural infection, but also to the vaccines that are being developed and deployed. So let's talk about the vaccines themselves for a moment. There's two vaccines that are approved in the United States under emergency use authorization order from the FDA. And that's authorized for use, not approved for use. If I said approved, it's wrong. These are terms of art. Approved means the FDA has fully vetted the data and has actually approved the drug for use. Emergency use authorization means the FDA has reviewed preliminary data, has concluded that the product is safe to use. There's a societal emergency that makes it less risky to use the product than to suffer the consequences of not using it. That's where emergency use authorization comes from. So both the Pfizer and the Moderna products are issued under those authorizations orders. Both of them are complex to use. They have cold storage requirements. The Pfizer one must be stored at -70 and colder. Once it goes to a warmer refrigerator, freezer type temperature, then the lifespan of that particular product, you must use it within several days once it gets to that level. The Moderna product, you can store it in a regular freezer. You can then transfer it and it's good in the regular freezer till the expiration date of the lot, which is usually several months. If you go ahead and thaw it, it's good for 30 days. If you go to room temperature, it's good for 12 hours. If you pierce the vial, it's only good for 6. So there are fairly strict storage and cold condition requirements imposed on these viruses. These are on these vaccines, they're very, very different from the flu vaccine. There are other vulnerabilities. For instance, if you violate those cold storage requirements, the vaccine is no good. You have to discard those doses. The messenger RNA, these are messenger RNA vaccines. Basically, the messenger RNA it's a little strand of genetic material, RNA genetic material, that instructs your muscle cells at the site of injection to produce spike protein, molecules comprising the spike protein of the virus itself. Those spike proteins are completely harmless, but they activate your immune system against the spike proteins. So there's no way either one of these vaccines can hurt you genetically or in any other way. They simply cause your body to produce a harmless facsimile of the spike protein of the virus. Your immunity develops against that. So when you're exposed to the real virus, your immune system kicks in and fights it from the beginning of the first exposure. That's how the messenger RNA works. Problem is, the messenger RNA is very fragile. So if you shake a vial of either one of these vaccines, it'll denature, it'll break the mRNA fragments and into fragments, and it's no more good. You have to discard it. If you drop a vial of this stuff, either vaccine, it'll break the RNA strands and it's no more good. So you got to be very, very careful in using this thing in order not to waste doses, either by violating cold storage or traumatizing the vials. I've had people ask me, well, what about shipping? It's frozen solid shipping. So shipping is much less risk. Once it goes into thawed liquid form, that's when the susceptibility to damage goes up. Another complexity to this vaccine is the fact that it's being used under emergency use authorization, and that comes with some requirements. So everybody that gets this thing ethically must have access to and hopefully review the appropriate FDA emergency use authorization order and understand it before they actually take the vaccine. So that's a step that must be made. You have to obtain informed consent from people to, flu vaccine that's approved. You don't need informed consent. to administer a product that is approved by the FDA. This one, if it's emergency use authorization, you must obtain informed consent. So people need to understand what they're agreeing to. There's a health questionnaire that accompanies this, and there are several questions on that health questionnaire that could slow down the process. If somebody's pregnant, for instance, the clinical trial data for neither of these vaccines included pregnant people. So the American College of Gynecology and Obstetrics has recommended that pregnant people get the vaccine because that's less risk than the disease to pregnancy outcomes. But that's contingent on pregnant people having the ability to talk to a provider and ask questions. So somebody comes in pregnant, wants the vaccine. If they haven't already talked to their doctor, then we need to talk to them for a few minutes and answer their questions and make sure they understand, what they're agreeing to. That all takes time. Previous COVID infections, history of anaphylactic reaction. With this vaccine, the anaphylactic reaction is maybe 10 times, it looks like at this point, 10 times higher than flu. That is still a very, very tiny number of people. It's like 1 in 90,000 people, but it's still significant enough to where we have to pay close attention to people. So when you get this vaccine, if you haven't had anaphylaxis before in response to something, even a bee sting or food or whatever, then we watch you for 30 minutes. For 15 minutes. If you have had a really severe allergic reaction to something, then we watch for 30 minutes very closely. So that's an additional requirement. So if you put all that stuff together, from registration through the health questionnaire to injection by the provider of the vaccine, through the 15-minute observation time, patients are on site for about 25 minutes getting this vaccine. There's hardly any way to really accelerate that process and still be in compliance with what's safe and what's right. To put that in perspective, if we run a flu point of distribution exercise, a drive-through flu clinic, which we do every year, the people are on site probably less than 5 minutes. They drive up, they give us their registration information, they go get their shot, and they're gone. So there are built-in liabilities to the vaccine and built-in steps that slow the entire process down. So that's the current vaccine usage. In the pipeline are the at least Oxford AstraZeneca vaccine. That's in use in the United Kingdom now, in wide use. So the data from their clinical trials, as well as population data that being developed in the UK, is available to the FDA. So when Oxford AstraZeneca applies for emergency use authorization here in the United States, hopefully the FDA can look at all the data and give them authorization pretty soon. That vaccine has no temperature requirements. It's a viral vector vaccine. It's not messenger RNA. So it's a hardier vaccine. You don't have, if you shake it or drop it, it's not going to be hurt. So it can be used at the community level much, much easier than these other vaccines can. There'll still be informed consent and all the questionnaire and all that, but at least there won't be the potential for wasting doses. And then there's the Johnson & Johnson vaccine, which is also a viral vector vaccine. It's made from a virus that's similar to the COVID-19 virus, such that if you develop immunity to that harmless virus and it represented in the vaccine, your body will have immunity against the COVID virus as well. That's similar. That's only a 1-dose vaccine. One of the biggest limiting factors for these vaccines that we're dealing with now and the Oxford AstraZeneca is 2 doses are required. So the interval for the Pfizer vaccine is 21 days. The interval, at least, you can go longer than that and be fine. It's not recommended to go shorter than that. With the Moderna vaccine, it's 28 days. So if you think about that, if you're running a clinic at full capacity on day 1, and you have about 500 people with appointments, then at 28 days from day 1 or 29 days, whenever, you have to have another 500 appointments set aside for the second dose. So your entire, unless you increase somehow your vaccination capability over that 28-day period, You go full tilt for 28 days, and then you re-inject the same people for the next 28 days. And then you go full tilt. So really, you're only doing one group of people every 2 months. Like I said, unless you somehow increase your vaccine capability. That's a huge challenge in using these 2-dose vaccines if you're vaccinating literally hundreds of thousands and hundreds of millions of people. There are workarounds for that, but we're having to invent them as we go along. Okay, so you can see that's a big challenge, the 2-dose regimen. Johnson & Johnson, I believe, is only 1 dose, so there's another advantage to that. So now that discussion about the 2-dose and how that affects our throughput leads us to the third topic, which is community vaccination capability. Most everywhere, nobody, there were pandemic plans in place, but as the old military adage says, no plan survives first contact with the enemy. So this being a novel virus that no vaccine exists for, a flu pandemic, you're kind of got an advantage because you've got a pipeline to rapidly create flu vaccines. With this virus, all the vaccine capability had to be developed pretty much from limited work done to this point on trying to develop vaccines against coronaviruses. That's a very difficult task, by the way. So we had to start from scratch, and then we had to take our shot making or shot injection capability at the community level, figure out what it is, and then figure out how to actually use this vaccine, and then try to build out and increase our community vaccination capability. And that's happening in every community, in every health district across the state. I know there are people from other places than Three Rivers, so I'll go over our current plans in Three Rivers. So what we did is we recognized immediately that there are several types of places that can give shots, that routinely give shots. In the health district, we have a baseline capability to do large-scale vaccination events. So we immediately activated our capability, learned how to adapt our processes to this particular virus, and started working as hard as we can to vaccinate people. Our large-scale events, we're a small health district. We're a big health district, 10 jurisdictions in several towns, but our local health departments are very small. There's only 4 or 5 people assigned to each health department. We only have 10, we have 11 nurses for 10 jurisdictions, and that's staffed for normal operations. Our normal mission in the health department is things like family planning, sexually transmitted illnesses, the occasional unusual infectious disease like tuberculosis. We have WIC, we have a Ryan White HIV outreach program, and we have our some home visiting aimed at teen pregnancy type programs. We have our environmental health program for septic systems and food permits and all that, but we're staffed for normal operations. Faced with a beast like this pandemic is, with all of the additional duties from contact tracing, epidemiology, tracking the thing, contact tracing, case investigation, executive order compliance. I mean, there's a whole host of things that we've had to do. So we've had to ramp up. And now comes the vaccine program, the vaccination program, which is enormous. And I'll describe that in a minute. By the way, one thing I forgot to say up front is I've been working as a physician for 44 years now. In my entire career, I have done everything I can to be frank and honest and speak ground truth as I see it. That's what I'm going to tell you all today. So I'm not pulling any punches. There's nothing about this except what we're dealing with at the ground truth level. Okay, so I'm going to be as honest with you as I can. So in our health district, we have built up the capability to vaccinate in any given we call them point of distribution exercise, about 500 people a day. If we really push, we can do that. That's about a 12 to 14-hour day for our vaccination team. So without really running our people into the ground, we can only do that about every other day. We have to do one, then we have to recover, deal with all the data, deal with all the administrative aspects. And by the way, the appointment system is going full bore in the background to this. And then the following day, we can do another one. Okay. So that's our point of distribution methodology. We also have focused teams of public health nurses. By the way, our big shot teams are a couple of folks that we hired, that we were allowed to hire nurses to act as vaccinators, and then MRC volunteers. The mainstay are a couple of docs, physicians that are retired in their 70s that are serving every day or every other day on our shot lines as vaccinators. They're doing a spectacular job, but we're heavily dependent on our volunteers for administrative support and actual vaccine handling and administration. So we took our public health nurses and we split them into teams, and they're going to aim at places like schools and local governments and courts and manufacturing and other critical infrastructure. They're actually going to critical infrastructure places where people are being exposed. And these are places where you can't help but be in a communal environment, a congregate environment, and get exposed. To school, for instance. If we're going to have kids in schools, the teachers are going to be there. At this level of community transmission, COVID is there as well. So we're completely dependent on our masking and social distancing and things like that to prevent transmission in those settings. Those people need to be vaccinated to keep those kids in school. Court systems, they're unavoidably exposed, same way. Local government with the essential functions of government, same way, and on and on. So the nurses are doing that. The second big source of injections are hospitals. Hospitals can take care of the patients that are enrolled in their healthcare system, that are their outpatients, and they can, as well as their inpatients. And they also, both hospitals in our area, Riverside and Bon Secours, have very graciously willing to volunteer and get involved in community vaccination opportunities as well, vaccinating people outside their healthcare system. And the third group of vaccinators are the community vaccinators. These are medical practices, pharmacies in the community, free clinics in the community. That's another source of people that if we can get the vaccine to them and get them qualified to use it, they can also enhance our vaccination throughput. So at the moment in Three Rivers Health District, combining all of those folks that we've got qualified thus far, and by the way, in order to get qualified to receive this vaccine from the CDC and to use it, you have to not only have the vaccine storage and handling capability and understand all the administrative requirements and ethical requirements, but you also have to be trained in the special procedures to use both the Pfizer and the Moderna campaign. So, and you got to be approved by the CDC. So there's an effort we can't just give this stuff to everybody. They have to qualify, get on the CDC approved list, and then we can either order it for them under optimal circumstances, or we can redistribute it to them. All of this is complex because of the nature of the conditions under which this vaccine is being used in the vaccine itself. So those are the community resources at this point in time, and we will expand this as we bring more pharmacies online. I haven't included in that the Walmarts and the Krogers and the CVS and the Rite Aids and the Walgreens. That's another big source of potential high numbers of vaccine capability. But with what we've got online thus far, our current vaccine capability is about 7,200 doses a week. The CVS and Walgreens are involved in federal partnership phase 1, which is aimed at the nursing homes and the long-term care facilities, that in retirement assisted living facilities. That is going slower than originally anticipated and desired. So they're actually needing help from some of the community-based vaccines, which the vaccination capability, like some of the other pharmacies so the VDH is trying to organize help for those federally funded pharmacies to try to get through the long-term care facilities and the assisted living facilities. And remember, all of those people need to be done twice. So they got to go through once, and then they got to go back and go through it again before they're done. When at some point in the future, there's a federal partnership phase 2, where those same big pharmacies are going to be theoretically given vaccine, and they're going to be able to vaccinate in the community just like we are. So I'm contacting those pharmacies in our district. I'm trying to understand, what their capabilities are. What if you think about a pharmacy, you walk into the pharmacy, you go through the store to get back to the pharmacy counter in the back. If you get your flu shot there's this little small waiting area, and the pharmacist comes out after you wait a while, gives your flu shot or your Shingrix or whatever, and then you leave. That is not a scenario that is amenable to 200 or 300 people a day, right? So I got to figure out how the big chain pharmacies are going to try to increase their throughput, or if they're going to increase their throughput. But I imagine they will. So there will be other community resources like that coming online. Another thing is, and you see this being done in some states, I think West Virginia has done this to advantage. VDH is exploring this and will do this as soon as possible. You can do large scale point of distribution exercises using federal assets, the Air National or the Virginia National Guard, augmented by active duty military, medical personnel who can give injections. All this can be coordinated with the help of FEMA, and other assets at the federal level can be engaged to bring to the states large scale vaccination centers that can maybe be up and running 7 days a week. These things, I'm not sure what the scale of their throughput is, but at least 1,000 people a day, maybe several times that. But the vision at the state level is to activate those sorts of resources regionally as soon as possible. And another potential way we could expand our vaccination capability is using commercial vaccination firms. Okay, there are commercial firms, just like there are testing firms, that can be contracted to come and hold vaccination events. And those things can be leveraged probably at the district level once we get to that stage. So that's our community vaccination capability that we have organized thus far and that we're building out. I'm communicating with all of these entities that can do vaccinations. I'm actually going out to practices and training them myself in the use of the vaccine. And in the future, hopefully, when we get vaccine supply, and that's the last thing I'll talk about is the vaccine supply. Hopefully, when we get supply in the future, we can get all of those people engaged. And I would like to get our Three Rivers organic capability up to at least 10,000 doses a week. We'll see how successful we are in doing that. But we'll build that out over the next several weeks. Now let's talk about our Three Rivers plan. And this is different from district to district in the Virginia Department of Health. One thing that, the federal plan, Operation Warp Speed, pretty much engaged manufacturing and procurement of vaccine, and then transport of the vaccine to a central distribution point in Michigan. All of this vaccine is owned by the federal government. It's a CDC product, so we're using it under the CDC rules. But once it gets shipped to the state, the federal involvement completely ends under the current model. And the states are then responsible for implementing their own plan throughout each state. So there's wide variability state to state and even within states with regard to how this thing is being done. So in Three Rivers, we have call centers on the Middle Peninsula in Gloucester, and if you go look at the Three Rivers website, you can see a phone number that you can call. The people in that call center will take, and it's in the Gloucester Emergency Operations Center. They'll take names, and we're maintaining a master list with many thousands of names on it, and we will call those people back for appointments within the system someplace. So that's one way you can access an appointment. The other way is there's a link on our website that goes to a Jebbit, Jebbit is the name of the company that runs this thing, a Jebbit survey. And that survey tool was initially designed for people to click on and easily find out their phase eligibility group. When this thing was approved, the CDC's Advisory Committee on Immunization Practices recommended, based on ethical considerations, phases of deployment of this vaccine. The first phase was healthcare workers, and we completed our phase 1 activities in Three Rivers last week, along with our hospital partners. Well, I'll get to the phases in a minute, but just remember that these are in phases, right? So the Jebbit tool was designed to let people know what phase they were in and what locality they could expect to seek an appointment in. It did not lead to an appointment. A lot of people who use that tool thought they had registered, because it takes your personal information. They thought that they had registered for a vaccination, but they didn't. It's a repository of information. So we leveraged that tool last weekend what drove us to do that basically was expansion of phase 1B, which we'll talk about in just a second. But we leveraged that tool. We called the data managers of that tool, of that Jebbit sign up. And anybody who has done that in Three Rivers, their names are being sent to us. And we add their names and contact and callback information to our appointment lists. And we will call people back on those lists with appointments as soon as we can. So that's our inroad for vaccination appointments. There is right now we're doing phone calls in the Jebbit tool. The original vaccine administration management system, virtual tool to make appointments and manage inventory and everything else that the CDC developed doesn't work real well in rural Virginia, because at least 15% or more of our population does not have access to the internet, doesn't have email accounts. So we really couldn't use that tool equitably. And that's proved so cumbersome that it's actually being replaced all over. The new appointment system and management system is called PrepMod. Our people are training to use that now. So we're probably gonna go from a callback for appointments to those who have email access, and email through, and anybody who's signed up virtually probably has this by definition, has this capability, but we'll send them an email through the PrepMod system and they get an appointment that way going forward. Right now, from the time we went into phase 1B last week, we have thousands of people already signed up for an appointment. So that's our current status in Three Rivers. Now let's talk about the eligible population for a second. I've told you our throughput capability is currently configured. Everybody combines about 7,200 injections a week. So in phase 1A, that's the healthcare workers, there are about 3,000 of those scattered throughout the Three Rivers Health District. And we were able to do that population in combination with the hospitals in about 3 weeks. And remember, we've built up our vaccination capability. It wasn't nearly 7,200 when we started this exercise. We didn't even know what kind of vaccine we would get, a month or a month and a half ago. So we had to build it from scratch. Phase 1B, without the addition of ages 16 to 64 and 65 plus, phase 1B has about 46,500 people in it. Now you guys are all in phase 1B. So a week and a half ago, Secretary Azar at the Department of Health and Human Services announced that nationally, they were opening the vaccine opportunities up to everyone aged 16 to 64 and 65 plus, and they were releasing the national stockpile to try to get shots in arms. If you add 16 to 64 and 65 plus, that 46,430 population goes to 130,800 people. now eligible for the vaccine all at the same time. And remember, this is 2 shots. So if we figure in our jurisdictions, a lot of people are older, a lot of people have chronic health conditions. So for planning purposes, we're thinking somewhere between 60-70% of people are going to want this shot at least. Probably higher in our area than in some other areas of the country where people are a lot younger. So say we have 100,000 people that want shots in Three Rivers Health District, that's a total of 200,000 injections. So if we can get our vaccine capability to 10,000 a week without big federal help and people being willing to drive an hour or two to get a shot, it would take us best case scenario 20 weeks to get through phase 1B if we could build our capacity to that level. Now, we always knew, and every, it was commonly said at the national level and even at the state level, that the vaccine program for an effort for the COVID-19 pandemic is going to take many months. We're going to be vaccinating people into next summer. But the set of circumstances over the past couple of weeks, with a huge group of people becoming eligible, the big push to get shots in arms, the news that there's been ever so many millions of vaccines distributed and only a fraction of those injected, it's created the illusion that there's this big backlog of vaccines sitting on shelves that we're just not giving people, okay? There's another requirement to actually record a shot. It doesn't really matter what your inventory, what the reality of what's in your freezer is. If you give a shot, it has to go back to the CDC to be counted. In Virginia, that means it has to go into the VIIS, the Virginia Immunization Information System. That's the final repository of all vaccinations in the state of Virginia. And there's been problems with linkage between the CDC systems and the state immunization systems. And there's problems with data entry backlog and that sort of thing. So the reality is we've given a lot more shots than it looks like we've given based on an inventory, because as far as the CDC is concerned, if it doesn't appear in VIIS, it didn't happen. So we're all scrambling now to try to fix the communication glitches and make sure nobody has a data backlog. So in real time, what the CDC shows we've done is what we've really done. Okay, that's another problem with this. But no matter what we do, it's going to take many, many weeks. It's going to take months to get through this all over the state, just for the sheer number of people involved. Now, let's talk about the vaccine supply for a minute. We really don't know. We heard last week that there is no federal stockpile. Theoretically, for every dose given of this vaccine, there was a dose reserved for the second shot. I think that's still the case. We are getting doses that are dedicated to the second shot starting this week, actually. So I think that's still the case, but the forward capability for new shots is a huge question. So we don't know what that stockpile is at the federal level yet. We don't know what the Moderna and Pfizer manufacturing capability is. If we don't have vaccines on the federal shelves, which it doesn't look like we do, then contracts and procurements using the National Defense Procurement Act need to be made with Moderna and Pfizer to manufacture more vaccine for this country. And remember, we're in competition in a world market at this point. We don't have exclusive rights to either one of those companies. We don't know how soon the Oxford AstraZeneca vaccine and the Johnson & Johnson vaccines will come online. Hopefully in the next 3 months, or maybe sooner, maybe several weeks, but that's an unknown. In the meantime, we were informed yesterday, we knew this was coming, but we're going to receive very severely reduced allocations over the next 6 weeks. Virginia is only going to get 105,000 new doses of vaccine per week. The governor wants to get to 50,000 shots a day. across the Commonwealth, that supply would be used up in 2 days at that rate. Okay. If you break that down to the district level, it's being allocated to the districts at per capita criteria based on population. And it looks like we're going to get in Three Rivers for the hospitals and practices, pharmacies, and health department combined, we're going to get less than 25% of what we can actually deliver at this point. So we're going to have to figure out how to prioritize those and allocate those doses. But that's going to slow us down. That's going to be here for 6 weeks, probably 6 weeks at least, unless something happens and there's things we don't know. We're counting on at least 6 weeks to 2 months in this mode. So it's going to add several weeks to the length of the overall campaign. So I'm thinking for my planning purposes in my health department, this is a very, very rapid ops tempo for all of us, operations tempo for all of us, as I'm sure you can see. And it's like the healthcare system in general. There's nobody standing behind us. We're fully engaged on all fronts, and there's no second VDH to take this over. There are really no reserves. So we're it going forward. So it's going to be a really, really hard push over the next 6 months. People ask me, when can I get my shot? And I honestly don't know. If you're on one of our appointment lists and you were fortunate enough to have contacted us very early in the process, we will get to you as soon as we can get to you. We are giving shots. People will get shots. We have considerations to make in this severely reduced availability of vaccine. How do we prioritize things like schools versus things like, other people like 75 years and older? Do we discriminate and go ahead and have and give shots to people 75 and older and not do 16 to 64 and 65 to 75 with chronic illnesses and all that at this point? These are very difficult decisions, and we don't have direction from centrally for any of these decisions at this point. So all of that's TBD, but we have to go through those things. So it's a long campaign. Nothing's going to happen fast unless you are a patient in a healthcare system that has capacity to get you in, or you got on our appointment lists early. It's all going to be delayed, and it's going to be really hard. That's the bottom line with this. The good news is we will get more than adequate supplies of vaccine. I have no doubt of that. We will build out our vaccination capability here in Three Rivers to better than we have now. We will get federal help with regard to big vaccination centers to get people through faster. And I can tell you, the healthcare workers, when I see my own staff and when I go out to the healthcare workers in the practices, I was in practice in Gloucester the other night, teaching the folks how to use this vaccine. Several practices came together in one venue. And when I got through with my showing them how not to ruin the vaccine and how to use it, a couple of the nurses sitting there, one turned to the other and she said, our brothers and sisters in the hospitals have been bearing the burden of this all this time. They've been at high risk and taking care of the COVID patients and exposed and everything else. Now it's our time. It's exactly what she said. This is our time. This is our time to really make a difference in the COVID-19 campaign. And that almost brought tears to my eyes. Okay. That showed me very clearly that the heart and soul of the healthcare workers all across this state are absolutely dedicated to doing everything we can, weekdays, weekends. My team is going out this weekend in several different directions to try to get vaccine to people who can't get it any other way. We have to go to them, okay? Our ability to do that will be limited going forward based on supply as well. But we'll work weekdays, we'll work weekends, we'll work holidays, whatever we need to do to get us out of this campaign, we'll do it. So with that, I think I've talked enough, and I'd be happy to answer any questions anybody has.
All right. Thank you so much, Dr. Williams. And on behalf of everyone here locally and on the call this morning, we just like to thank you and your staff and all healthcare and frontline workers for all of their help and dedication through this effort. It certainly would not be possible without you all. So thank you every bit for everything that you do. We really appreciate that. Looking at the chat window, I see we've got a couple of questions for you. The first question was in regards to the comments you made on the vaccine and the fragileness of the vaccine. And the question is, regarding the fragments, if it has been dropped or damaged, what could be the consequences if that vaccine was administered?
It just wouldn't work. It wouldn't do its job of sending so the message is scrambled it's messenger RNA. So the way to look at it is the message is corrupted, and the message would not tell your cells to produce the spike protein for as the target. So it wouldn't hurt you, it just wouldn't work.
All right, the next question is regarding safety. And the question is the vaccine safe for allergy sufferers, and what information may be available regarding future side effects for allergy sufferers?
The biggest risk is a history of what we call anaphylactoid or anaphylactic reaction. That's a severe immediate reaction to an allergen, to a substance that you come in contact with that causes your immune system go into overdrive, the acute aspect of your immune system to go into overdrive. So your tongue swells up, your airway swells up. It's an imminent threat to life. That's the biggest immediate risk of any drug, but of this vaccine as well. That's higher than it is with flu, but still very rare, maybe 1 in 90,000. I think across the state of Virginia, I've heard of a couple of 3 anaphylactoid reactions thus far that have required epinephrine and then transport to hospital for safety. We do have epinephrine on site that we inject into people if they have such a reaction in the observation area. For people so that's the biggest risk. From a long-term perspective, the consequences of this vaccine are really very, very few or unknown at this point. We'll know more as more and more people get it. The population of people in the clinical trials was not very big. It was enough to convince the manufacturer and the FAA that the product was safe and effective, or looked safe and effective. But the real behavior of this thing will emerge, once more and more and more people get it. So, you might hear that some people have suffered Bell's palsy with this vaccine. In reality, when you look at the distribution of Bell's palsy in the population and in the group of people getting the vaccine, it didn't occur at any higher frequency than it did in the population. So whether the Bell's palsy was related to the vaccine or not is unknown. There's some things like that. With regard to people who are allergic to a lot of things, if they don't have a severe allergic reaction right off the bat, I'm not aware that if that can be interpreted as meaning you have a higher or a more active immune system, people might have more side effects to this thing. The side effects of both of these vaccines are usually a sore arm, maybe feeling a little bit like you're trying to get the flu or something like that, maybe a few aches and pains. But generally that's over in a day or 2 or 3. The CDC, when you get the shot, you'll have the opportunity to download an application from the CDC called vSafe. This is a thing that'll query you every day by text message to go to the website and enter your side effects. So the CDC is tracking these side effects and to give us more data and understand them more. But most people, the side effects are mild and are over in a day or so. I'm not aware of any long-term health effects that result in people with allergies from this vaccine at all at this point.
All right, the next question that we have, Dr. Williams, is 2 questions, but I think they relate to one another. The first one is, are all the types of vaccines available from the different companies at vaccination sites for people to choose, or do you have to get what the health department or that site has access to? And then the second question related to that is, do folks have the ability to choose which vaccine to take? And if so, how do they go about finding where that particular vaccine choice is being administered?
Currently, the Pfizer vaccine, because of the cold storage requirements, minus 70 degrees, the Pfizer vaccine is mostly available through the hospitals and healthcare systems. All the hospitals and healthcare systems, or most of them, have outpatient services attached to them. Groups of doctors that do clinics, outpatient clinics, and those are the places where you're most likely to encounter the Pfizer vaccine. The Moderna vaccine is used more at health departments and other community providers and pharmacies and places that don't, like local pharmacies, places that don't have that really severe cold storage capacity. Currently, the vaccine supply is so limited that basically you take what you can get if you can get it. Eventually, the vision is to have the software set up to where you can go to your local health department website, click on a function that takes you to scheduled vaccination clinics, stipulate which product you want, and then make an appointment at a clinic that is offering that product. We probably won't mix products at a clinic. They'll be all Pfizer, all Moderna, all AstraZeneca, all J&J as things go forward. But as the vaccine supply increases, eventually we'll probably get to a point where people can choose their clinic, get a vaccination within several days to a week, choose the vaccine they want, and proceed that way. But that's probably several months from now, when the procurement process gets better, the supply gets better, the other vaccines come online, and we get through some of the initial high demand and backlog.
All right, we still got a few questions rolling in. The next question asks, could you define or add clarity to agricultural workers and give a list of who may fall under that term in phase 1B? And a follow-up to that. Go ahead.
Yeah, rather than try to parse down to, what particular category of person qualifies, in general, if you're part of the food infrastructure, you're involved in the production of food, the transportation of food, the marketing of food, then you're a critical infrastructure worker, and that includes aquaculture and folks that are engaged in getting food from marine environments, as well as people that are growing food in any capacity on the land. So if you're involved in that, then in my mind, you're in phase 1B as a critical infrastructure worker. In my mind, if you're supporting all those activities, you're in line as a critical infrastructure worker. So I would apply big principles like that. And hopefully when we get enough vaccine, we won't be at the point where we have to prioritize, okay, who do we vaccinate? Do we vaccinate a teacher who's exposed in the schools to keep the schools open, or we vaccinate an 80-year-old person who's at high risk from the disease? That's where we are right now. And those are horrible ethical decisions to make. But in the future, we won't have to do that. So that I would stay at high level for definitions for now. And was there a second question to that?
So the second question that would relate to that, Dr. Williams, is where would farm families and their spouses fall into that phase? So for instance, if a farmer qualifies, does his or her spouse also qualify, since they're both in agricultural production?
If they're in agricultural production, at this phase, with this thing being a scarce resource and trying to target the most vulnerable people, it really is based on exposure and criticality. So for instance, the teacher clearly qualifies, who's in front of the school kids, clearly qualifies in phase 1B under any circumstances to be injected, but her family does not, or his family does not. Now that doesn't make much sense, because one of the greatest exposures of anybody is what happens at home, right? People going out and coming in and bringing the virus home. But under the ground rules, it's only the workers that are eligible. I don't know how that translates to agriculture. I mean, if I know most farming families, they're all involved. You know, if I were living on a farm, I would think that. I mean, typically, I haven't been a farmer. I haven't lived on a farm, but I've known some farmers, and I do not know any farmer whose family was not involved in supporting the entire farming effort, whether it's tending to the farm animals or actually out driving the tractors and planting the fields and managing the, you know, the planting schedules. I mean, I don't know how to separate a farmer's family out. So when we get to that phase, you know, if somebody tells me, hey, my whole family is involved in this effort, then that's the way I'm gonna roll. Hopefully by that time, we won't be at this real scarce resource, high priority issue, and it won't be an issue. Have I characterized farming families correctly?
Yeah,
Is that
I,
pretty?
I think that's a great answer to the question, Dr. Williams. I think that probably, if it doesn't, whoever asked that question, if you could just reiterate that, it would be helpful. The next question is regarding any documentation that would be needed to verify your status as one of these essential workers. So for this presentation would be for agricultural workers in the category 1B. Would they need to provide any type of documentation at the vaccination site to justify that?
You know, I don't, that's another, trying to credential people, you know, that's another step, limiting step in the process. So we're in order to process people, we all got to be vaccinated eventually, right? So in order to process people through faster, we're not credentialing people. I mean, if somebody shows it, when we get to this stage of where we're taking 16 to 64 with chronic medical conditions, we have those folks on our list now, and we're actually under the governor's construct, we're calling those people back. With the new vaccine shortage, I don't know what's going to happen, but if somebody shows up 42 years old and says, I got a chronic medical condition, I'm not going to ask whether they got a note from their doctor. It's the honor system. I'm going to give them a shot and they're going to go on. I don't know how we can approach that any other way. Again, this becomes much less of an issue if we have an adequate supply. And once we've built out the throughput infrastructure, those are two limiting factors. Throughput infrastructure, which does not, we're putting it together and organizing it now, and vaccine supply. But credentialing is just a step too far. None of us know how we would effectively do that without grinding things to a halt.
All right, the next comment that we had in the chat box is from one of our state level administrators, Dan Gorlick, and the comment was, excellent presentation, Dr. Williams, thank you. Virginia Cooperative Extension agents are well positioned to help the Virginia Department of Health get information about the vaccine into the hands of agricultural producers and the agricultural community, thereby enabling them to make their own decision about how they might like to proceed. From the Virginia Department of Health perspective, do you see a partnership with VC agents as being helpful for your efforts with informing the agricultural community? And Dan, I'm not sure if you're still with us, but if you want to go ahead and reiterate or explain that further, please do.
Thanks, Robbie. I am still here, and I think the question captures the gist there. And thank you again, Dr. Williams. I've really appreciated this information this morning.
Thank you, sir. Yeah, I think the more partnerships we have on a broader front, the better off we are. You're kind of touching on the concept of vaccine hesitancy, which a lot of people have. A lot of people think about this vaccine and they say, well, yeah, this thing it's being used in an emergency. There's not much data. I don't really know what it's going to do to me. I don't trust government to begin with because I don't know that what they're telling me is true. I mean, there's all kind of variety of personal reasons where people would avoid taking this vaccine. And I haven't even touched on vaccine hesitancy in this presentation. What I'm telling people with regard to that is that the demonstrated potential power of this virus I mean, I'm looking at, at a screen that's showing 400,000 people dead and rising. Okay. And I'm looking at hospitals overcome, and I'm looking at, the effect and the long-term health effects, many of which are not even understood and known at this point. This is a very, very capable virus that can attack in a variety of ways. Yeah, most people who get it, it's kind of like a flu, and they get over it quick, or maybe no symptoms at all. But still, the long-term health effects we don't really know. We know this virus goes to multiple tissues in the body, even if you don't know it's there. So does it hide out? What does it do later? We don't know. So it's far, far better. The vaccine is orders of magnitude safer to take the vaccine than to get the virus. Okay. That's my choice. That's what my family will do. That's what I will do as I can. And so that's what I advise people to do. Much safer to take the vaccine than to take your chances with the virus.
All right, the next question is, will the COVID vaccine potentially turn into a yearly vaccination program like the flu?
That is unknown. And this virus genetically drifts. We know that there are at least 4 new variants of this thing that are involved in major outbreaks across the world, and those variants are making their way through the world. The UK variant has been identified here in multiple states. There was a follow-on question I saw pop up in the chat. Currently, the vaccines as configured by Moderna and Pfizer in the laboratory, the antibodies produced by the vaccine and the immune reaction from the vaccine does attack the shifted viruses. So some of those, like the one in UK, has, I don't know, 17 or more mutations. One of the mutations is at the spike protein. The spike protein is what the virus uses to attach to the ACE receptors on cells in the airway and elsewhere. Okay, so that's the way the virus attaches itself. It then injects its genetic material into your cell, takes over your cell, and your cells produce virus particles. That's how this thing works. Okay, it's like a Trojan horse type of thing. But it actually invades your cells to turn your own body into a virus factory. But so there are mutations affecting that spike protein, but they're not big enough to where the current vaccines don't still attack it, if that makes sense. So that's what it looks like in the lab, and hopefully that'll prove true in real life as well. Now, are we going to need a yearly vaccine? Nobody knows what this virus is evolving to. Nobody knows what the end state of the virus will be. Most people think we'll probably drive it down to low levels by the summer, and it'll become kind of endemic at low levels, and it'll surface again at intervals, sort of like the flu does. It'll become a disease where contact tracing and trace investigation containment becomes effective at very low levels. As soon as you identify a case of COVID, if you isolate that person and quarantine everybody that's been exposed to that person, you can stop the spread at the single person. That's what containment means. Right now, containment doesn't mean anything except in very vulnerable populations like nursing homes and prisons and places like that. But when we get it down to low endemic levels, we can contain it. Whether or not what its potential to resurge at epidemic and pandemic levels is, whether or not we need to continue chasing this virus with different sorts of vaccines as it shifts, all of that's unknown. Most virology and infectious disease experts think it is very likely that we'll have to develop future vaccines against future variants of this disease. Whether or not it has to be every year or not depends on how long the immunity is and how capable the virus is in undergoing genetic drift to defeat the current vaccines. So that is likely, it is likely we'll have to get repeated vaccines that are tweaked to the latest virus, just like we do flu. But exactly how that's going to work has not yet surfaced.
All right, thank you, Dr. Williams. I see one final question in the chat window here as of this time. And the question is, are there any charts or resources that may compare the pros and con data for the 4 different vaccines?
I think the best thing to do, I'm not aware of any product that compares the 2 vaccines. The Pfizer and Moderna are close enough in mechanism of action and manufacture to be almost identical in effect. The other ones are very similar to other vaccines that we've all taken, sort of like the flu vaccine. I can certainly market that idea to our information, public affairs and information folks, and I will do that. I will take that notion back as the AstraZeneca and J&J vaccines come online. I'll see if the VDH can do a one source, one pager that compares the 4 so people can kind of know. You can search each product and you can look in the news. They have, like, the New York Times now has a vaccine tracker where you can sort of see individually what each one does, what its effectiveness is, and so on and so forth. So you can sort of do that, but you have to do a little work and read about them individually.
All right, Laura just posted a resource there from Roy, and it's a document from the Department of Homeland Security that provides additional guidance on essential workers and also defines agricultural workers. So if you're interested in further information on that, you can find that PDF resource in the chat window. One additional question, once individuals are vaccinated, will they still have to adhere to the quarantine guidelines if exposed to an infected person after that?
Yeah, that's an excellent point, and one that I neglected to talk about in my discussion with you guys. I'm kind of focused on vaccine supply now, as you can imagine. So yes, once we are injected, immunity from the first injection really doesn't start having any effect appreciably till about the 10-day to 2-week mark. And then it's kind of unknown how effective a single injection will be. But with 2 injections, more than 28 days apart, you're up at 95% level with both of these vaccines. With 1 injection, you're probably more down in the 60 to 70 to 80% effectiveness, and the duration of that immunity is probably less than if you got 2 shots. So it's important to get 2 shots. At the population level, since we don't know, we know how this thing works sort of in the clinical trials, but whether the vaccines are really effective at preventing infection or whether they're more effective at reducing the severe effects of infection, but people can still catch the disease and transmit it asymptomatically. Those are pieces of the puzzle that we really don't know at this point in time. That has to be, we have to, track people who've gotten the vaccine, see if they get infected, see if they're part of outbreaks, see if they asymptomatically transmit. All of that data will emerge over the coming months and year. But for the moment, the safest thing to do is, once you've got your vaccine, let's all continue our masking and social distancing because of the level of unknowns. It will become obvious over time. One clue we'll have, the strongest sign we'll have that it's safe to come out of this hiding mode we're in, is when the case numbers in the population drop way down. When we see those case numbers drop way down, okay, and it looks like the pandemic is under excellent control, that's when the public health authorities will start talking about, okay, or when they should start talking about, okay, we can go ahead and get in congregate environments again and have more exposures that if COVID is there, it's likely to transmit because it's probably not there. That's when we'll be able to do that. But from now until then, there's a lot of unknowns, and the safest thing by far, individually and as a population, is if we continue limiting our exposures.
All right, thank you, Dr. Williams. And I see we're about 10:15. So in the sake of time, we'll go ahead and wrap up this morning. If you have any further questions on the topic, please get those to any of the participating ag agents for VC Ag Today or your local health department, and we'll be glad to forward that information and get you an answer on that. So thank you again, Dr. Williams, for all of your time and efforts. We really appreciate the opportunity to be with you this morning. And thank you for your great information that you've shared with us and all the efforts you and your staff have been through and continue to go through. We really appreciate everything that you all are doing. If there's anything that we can do from VCE, please let us know, and we'll be glad to help with those efforts as best as possible. Thanks again to everyone else for joining us this morning. The presentation has been recorded, so you can find that at our VC Ag Today recording web link. You see that on your screen at the bottom of the slide there now. Also, just would like to take a few minutes to thank the production team for VC Ag Today, Stephanie Romelchek, Laura Maxine, Trent Jones, and Mike Broadus. And thank you to all of our fellow colleagues that have joined us today for this effort. If you would please stay on the line after the call this morning, we will continue the conversation internally for Virginia Cooperative Extension. So please do so if you'd like to participate in that. Next week on VC Ag Today, our topic of discussion will be farm agricultural resources and mediation. We'll be joined by some representatives from the organization Farm VA. So please join us for that. That will also be a VCE agent in service as well. So if you're an agent joining us this morning, please join us next week as well for another opportunity for that presentation. Finally, if you joined us this morning or have joined us for previous versions of VCE Ag Today, please help to evaluate our program and provide input. You can find the link there on your screen currently for the evaluation. It should take less than a minute to complete, and it's also been posted into the chat window there by Stephanie. So thank you, Stephanie, for that. Thank you, everyone. Appreciate everyone joining us this morning and taking their time on this Thursday morning. Please be safe, be vigilant. And if you have questions, please reach out to us. We'd be glad to help. I hope everyone takes care and has a great rest of your Thursday. Thank you so much, Dr. Williams.
Yes, thank you, Dr. Williams. That was excellent. All right, I'm going to take this as a learning opportunity for everyone. I'm going to stop the recording.